watch it and still be able to get the material. All right, so let's get started. So sexuality in the older adult. The objectives for today will list changes to the male and female reproductive system that occur with age. We'll describe measures to promote reproductive system health in older adults. Outline factors to consider in assessing reproductive system health in older adults, and describe the symptoms and management of selected disorders of the reproductive system. So having discussions with older adults or with any patient I find can be awkward when it comes to talking about sex. And that's because while it's far more out there and people are talking about it more in the public and in the media, I feel like in the professional context of a care provider with a patient, it still feels awkward and inappropriate sometimes, even though it's not inappropriate at all. I think a part of it is that there's a lack of knowledge because we don't talk about it so much in school, in nursing programs. When we're faced with having to have a discussion with a patient about issues of sex and sexual health, you can often feel like you don't have enough of a knowledge background to give good advice, and so having those conversations can be intimidating. This lecture will hopefully shed some light on general practices to keep in mind and general advice that you'll be able to share with your patients. It's means completely comprehensive of everything that could affect older adults with regard to sex, but it hopefully covers the major issues and will hopefully help you to be able to at least give basic advice to your patients. The most important thing to keep in mind is that sexuality is an important part of our overall health. And as nurses, not only gerontological nurses, but in general, it's important for us to be able to understand the importance of sexuality to health and be able to educate our patients about being safe and being able to enjoy their sexuality as best that they can. So we are focused on this class on the older adult and changes in the older adult. And some of the changes that occur to the female reproductive system are generally, they're all listed here, but in general, you can think of it as a general atrophying, thinning of tissue. You lose subcutaneous fat. And so that can make sexual behavior less comfortable. I don't know what happened here, my slides. There we go. Less comfortable, and also the appearance of the older adult woman can change because of that loss of subcutaneous fat and just the way that the body changes. The breasts become less firm, the nipples can change. So not only can sex become less comfortable for older adult women, but also body image can be affected by these changes, which can make sex less appealing. Just trying to figure out why I keep losing my slides. Okay. And with the male, there are also changes that occur. There's a reduction in sperm count, the testicles atrophy, there's a slight decrease in testosterone. It takes longer to achieve an erection, and erections are also more easily lost. And there's an enlargement of the prostate gland. And I feel like the enlargement of the prostate gland is an issue that I encounter almost every day with my older adult patients. You know, in doing an assessment with them, you ask them about voiding and is there any issues with voiding, dysuria, frequency, pain. And many of my older adult male patients do report having difficulty with urinary frequency and hesitancy, all related to the growth in the prostate gland. So this is something that I think you'll all be very likely to encounter in practice. Some of the conditions that are associated with these changes in the reproductive system, on the female side, as I mentioned, because the tissue is changing, you're uncomfortable, sex becomes less comfortable, but also you're more vulnerable to infection of the vulva, vaginitis, and there's also the female cancers of the female reproductive system. And we talked about cancer 2 weeks ago in our last lecture. There's other changes, dyspareunia, Nabothian cysts, which are small fluid-filled cysts that are on the cervix. These aren't just in older adult women, but they're definitely more common in older adults. And then changes to the actual sort of structure of the reproductive system with cystocele, rectocele, and prolapse, which are the most common. So here is an image of a normal reproductive system: the urine, the bladder, the uterus, the vagina. And you can see here in the case of a cystocele, the bladder sort of prolapses into the vaginal canal, or into it, but it sort of blocks it. And then the same here with the rectocele, you have sort of a prolapse of the rectum. And there's different treatments for that. A lot of them are like mesh treatments or different things that can be used to sort of hold the tissues in place. But that's managed by gynecologists who has specialized knowledge and skills in managing those issues. With the male reproductive system, you can have erectile dysfunction, benign prostatic hyperplasia, again, that growth of the prostate. And there are specific drugs on the market that are designed to help manage that issue. There's also prostate cancer and tumors of the penis, testes, and scrotum. And on the male side, I'm sorry, I keep losing my screen. You can have hydrocele, spermatocele, and varicocele. And this is just a picture image of those changes. So the hydrocele, you have a fluid buildup within the scrotum. With the spermatocele, you have a small sort of cyst-like buildup on the testicle. And in the varicocele, you have sort of an inflammation of the vasculature of the testicles. And then very common, you can find inguinal hernias in older adult men. From the physical changes with aging, there are also medical comorbidities that can affect sexual behavior. Of course, there's issues that can make having sex less comfortable if you're in pain, having any type of chronic pain or arthritis. If you've had surgery, you might be limited in how well you can move or how comfortable you are. There also might just be changes to the body, that could make sex less appealing, or have changes in the body image. Like if you have a hysterectomy, that can make women feel a little bit less like a woman when the ovaries and the uterus are removed. Prostatectomy, stroke, certainly that can inhibit your function. Incontinence can make sex very unappealing because you're having leakage of urine. Heart disease, diabetes, all can affect your stamina. Medications can affect your Medications can certainly have an effect, as well as alcohol consumption. And we talked back in our first lecture about how some older adults have an increase in alcoholism and alcohol consumption. So this is not just an issue for the young as far as alcoholism is concerned. But for those older adults who are sexually active, and there are many, it still is very important for them to practice safe sex. Older adults, like any adult having sex, is at risk for sexually transmitted disease, including HIV and AIDS. The number of older adults with HIV and AIDS is growing, which tells us that older adults are definitely engaging in sexual activity at a higher level. So the important thing here is to understand those risks, understand that our older adult patients are sexually active, and not hesitate to educate them about safe sex the same way we would with our younger patients. And so when you're performing an assessment about sexual behavior, one model that can be used to do an assessment is this PLISST model. And so with this model, it's basically basically sets up a structure for how to have these conversations with our patients, and not just older adult patients, with any patient. And it begins by asking for permission to begin a sexual assessment, or sort of opening the door with an open-ended question, such as, do you have any questions about sexual practices or your sexual health? And sort of creating that safe space, and open discussion and dialogue to have a discussion about issues. From there, you can provide limited information about normal and pathologic changes that may affect sexual health, and try to dispel any misconceptions. And this is in a general sense. And so giving general information about changes that affect sexual health for older adults, which can be very helpful and a nice way to set up a conversation by letting an older adult patient know that they're not alone. You know, perhaps the issue that they're bringing to you and asking you about is something that's very common. And so that can help ease the tension and make someone feel less uncomfortable about having a conversation about this. And then providing specific suggestions, you know, going from giving general information to providing more specific suggestions that are particular to your patient's issue. And then keeping in mind more intensive therapy, such as consultations with sexual counselors, if the need arises. On top of that, you also would do just a general assessment, as you do with all of our patients. But in an assessment geared towards sexual health, you're wanting to ask about pain, pain with intercourse, pain with urination. I'm sorry, guys. Is anyone flipping through the slides? If so, I think that it's sort of controlling the presentation for the rest of us. There we go. Oh, okay, I see. Okay, so I think you're all presenters, so you all do have the ability to through. So yeah, exactly. Please don't touch the slides. I'll control it for now. When it's time for the group presentations, then I'll let you all each individually control your own presentation. But for now, I think it's kind of getting us lost. Yeah, so when you're having your general interview with the patient, you're asking about pain with intercourse, with urination, pain, bladder pain, any discharge, what's the color of the discharge? Is there any odor to the discharge? What is the volume of the discharge? When did you begin to notice the discharge? And then any sexual dysfunction, not only physical, like painful intercourse, but have you noticed a new lack of interest in having sex? Because that might lead to issues about depression or other issues that need to be addressed and assessed. In your textbook, there's an assessment guide on page 320 that is very, very good and provides much more information about how to do this detailed assessment of a patient. With the physical exam, you want to inspect the genitalia for lesions, sores, breaks, or masses. Take note of any bleeding, discharge, odors, or other abnormalities. If it's a female patient and they have not had a gynecologic exam or mammogram within the past year, you want to refer them. But do that in consultation, of course, with their primary care provider. For females, you want to do a breast exam and also teach your patients about how to do a breast exam. There are many pamphlets that are out there that also provide detailed instructions on how to do it. I find that with teaching, it's always best to do a multimodal approach. So talking to the patient about it, demonstrating it in the office while you're doing it, and then providing a handout that they can refer to at home. Some of you may be thinking with this physical exam, is this part of an exam I should be doing routinely? Which of course the answer is no. For your general patient in the hospital, you're not going to be doing a GYN exam on every patient. This is really specific to patients who have issues that are relevant to that body system. Then you would want to do a GYN exam. And this is just one copy of a form that sort of goes through the process of doing a female exam. There are similar handouts and references for the male testicular exam, which is also important to teach our patients. So some nursing diagnoses: risk for infection, right? Because the tissue is changing. It's become more fragile in the vagina and of the vulva. So female patients are much more susceptible to infection. Risk for an effective relationship, readiness for enhanced relationship for those older adults who might have lost a spouse and now are ready to engage in relationships again and who are seeking advice about how to do that. And then, of course, altered sexuality. Nursing interventions: we can counsel our patient on self-care and body image, encourage good hygiene, especially for our female patients. And I keep going back to that because I see the older adult female patients so frequently who have had recurrent UTIs or who have that vulvitis. And when you see it in person, these poor women are miserable. They're in a lot of pain. They're very uncomfortable. You give them treatment to treat the infection if it's a UTI or what, but the skin, if the tissue is really inflamed and uncomfortable, it takes a lot of work with ensuring good hygiene and finding good barrier creams to use to get them under control. Other comfort measures that I've seen work really well are sitz baths. Some patients have used saline compresses. I've even seen patients in the office using like warm compresses down there when they're really uncomfortable. And I think prevention is really key. You want to prevent patients from finding themselves in a situation like that. And so teaching is very important about how to practice good hygiene. Also, douches, if patients are using that, especially in the older adult patient, their sensitivity to temperature is reduced. And so you want to make sure that they closely monitor the temperature of any douches if they're going to use them. But truthfully, you want them to avoid using douches, especially perfumed ones that have fragrances. You really don't want to put anything that harsh into the vaginal area because that will create a higher risk of bacterial growth, and you can see with that. Encourage cotton underwear, encourage lubricants when engaging in intercourse, and then encourage regular self-breast and self-testicular exams. The next two slides are just community resources that you can refer your patients to. And then we have some case studies. So let's see how we're going to be able to do this. So you all have audio. I'm going to read out the case study and then are you all able to raise your hand? Okay, great, perfect. So that's what we'll do. I'll read out the case study and then just raise your hand if you want to comment on it. And kind of go through that. We all have audio set up, so we'll be able to have a talk about it. So this is our first case study. It's a patient, Franklin. I'm going to be reading his case study in the first person. So just imagine you're working in a community health center and Franklin presents to you. I'm Franklin, I'm your patient. So hello, I'm Franklin. I'm at a crossroads here. All my life, I had to live under the radar per se. I had a life that my family and business associates did not know. I had a partner for 20 years who my family didn't know. You see, in my day, the 1940s when I was a teen, being gay was not as accepted as it is today. I know that it is not totally accepted today, but back then, you could lose your job if somebody found out. I lost my partner, his name was Bill, 4 months ago. I had a small group of friends who knew what he meant to me, but essentially, I had to grieve alone. Who would have thought that same-sex marriages would be a topic so many people would support? Maybe Bill and I were just born too early. I do miss him and the companionship we had. Is it too late to have that again? I wonder what my sister would say if I told her about Bill. So what do you all think? Any thoughts about our patient, Franklin? Yes, Riel.
I think that he, sorry, there's an echo. Do you guys hear that?
I can hear
No,
you.
it's just me. I think that he has depression that we can refer him to psychologists. We could ease his um, discomfort about talking about his sexuality because he has a long history of being repressed and not being allowed to speak about it. And so it's probably uncomfortable for him, even though it's now like totally okay in society. And as for his sister, um, we can suggest support groups, maybe.
Yeah,
That's what I
yeah, very good. Um, Regarding his question, is it too late to have that again? It sounds like he's seeking advice as far as is it possible for him to find romance again? Is it a good idea at this point? You know, he's grieving. Is it okay for him to try to find love again? What are any of your thoughts about that? How would you respond to him about that? Yes, Muriel.
I would say that it's never too late to find to have a romantic relationship or to find love in life, and that plenty of older adults are able to find spouses later on in life after being widowed or having other relationships, and that it's
Absolutely.
totally normal.
Absolutely. And I see it all the time, patients who find love in their 60s and 70s. So definitely letting him know that, you know, regardless of if he's older now, it's not too late. It doesn't mean you have to be alone. And it is okay to move on. You know, he had what sounds like a very beautiful love with his partner Bill, and Bill is gone, and it is okay to find happiness again with somebody else. And so letting him know that it's okay and sort of validating those feelings is very important. In addition to seeking out, you know, support, maybe even family counseling if he wants that as a opening to talk more about it with his sister and all of that. So very, very good. Any other thoughts about Franklin? Okay. So we have another case study here. So this one is an SBAR report. So imagine I'm Nurse Nancy and I'm giving a report to my nursing supervisor. And I'm working on a cognitive impairment unit at a assisted living facility. So I'm giving a report. So the situation, I have two clients currently on my unit who are exhibiting behaviors, and I am not sure what to do. They have been holding hands, kissing, and today we found them in his room alone together. The background, Gladys has been with us for 2 years and follows direction without difficulty. She's oriented to person and family and is generally quite happy. Charles moved onto the unit about a month ago and also carries a diagnosis of Alzheimer's disease and has been about the same orientation and has about the same orientation capabilities as Gladys. So he has Alzheimer's, but he is oriented as Gladys is to person and family. He had some agitation initially, but has settled into the unit nicely. The assessment, there is no noted fearfulness in either client. They have both had some mild agitation when distracted away from each other. Gladys did quite upset last night when another female resident sat next to Charles at the dinner. And so my recommendation to my supervisor, perhaps we should have a team meeting to discuss the policies of the unit. In addition, we should contact the families and see what their thoughts are regarding these behaviors. I am not sure that limiting the behavior is beneficial to either client. So what do you think about that? What if imagine you're the nursing supervisor and I just gave you that report, that concern? What would your thoughts be about it? And again, we have two residents at a long-term care facility, both oriented, one who has been diagnosed with Alzheimer's, who are sort of engaged in sort of like a romantic relationship with one another. Muriel?
Yeah, it's under my understanding because I've covered this subject for something else before, that in um, those facilities, the senior like living facilities, that under if they have the same cognitive level and functioning, they're allowed to have their privacy. It's part of their like patient rights to have be able to have privacy, and they're allowed to have private time with each other. In terms of the like jealousy and conflicts, though, that has to be addressed, I think.
Hmm.
Yeah.
Very good, Muriel. You're absolutely right. Does anyone else have thoughts about this case? This I've heard in clinical, other students have brought this up before, so I know it's something that we all think about. Um, any other thoughts? Okay. Well, yes, Muriel, you are right. The priority is to do an assessment of each client using the PLISSIT model, of course. The recognition of the absence of fearfulness is key in the scenario. So nobody's harmed here. And that's key. And in fact, it seems like the relationship, if anything, is bringing them happiness. So as Muriel said, just, making sure that they're safe. The one opportunity for sort of a bad outcome is with this sort of bit of jealousy that's been being there. So just keeping an eye on that. But as safe, that's the most important thing. The other thing that is recommended is to discuss this with the patient's families and make sure they're aware, particularly the patient who has Alzheimer's, just to make sure that everybody is aware of what's going on. And making sure that everybody is safe and understanding that the family members, if it's adult children, they might struggle with the idea of their parents like engaging in romantic relationships, and so counseling them through that. But we don't want to spring that on anybody either. So definitely keeping them in the loop on these discussions. All right. Any questions about that or anything else from this? Okay. All right. Well, let's move on and do our group presentation. This is just references. And so I am going now to turn it over to our hip fracture group. Whoever wants to take over, maybe I'll give it to Marvi Lynn. Is that okay?
Sure. Does that mean I'm just going to be the one to maneuver the slides?
Yeah. Let me just
Okay.
make sure you have control here. Make the
No, I think
moderator.
we all
Okay, there you
do.
go. Okay, all right, cool. Yeah, take it away.
Hi, can you listen me?
I can
Yeah,
hear
we
you,
can
but
hear you.
barely. It's like a little
Okay.
muffled.
Okay. Hi. Today we are good afternoon. Today we are presenting about hip fractures. I'm Sylvie, and other members of this presentation group are Sunhi, Marvi, Michael, and Carl. So, next slide. What is hip fracture? Hip joint is a ball and socket type of synovial joint that is formed by articulation of two bones, femoral head and acetabulum of the pelvis. And any break in the upper quarter of the femur is known as hip fracture. But injury to the acetabulum is not considered as hip fracture. Next. Here is a picture of different types of hip fracture, and they are named in correspondence corresponds to injury in different parts of femur. Among them, femoral neck fractures are most common. Next. Here is some statistics about hip fracture. Every year, over 300,000 adults aged 65 and older are hospitalized for hip fracture, and more than 95% of hip fractures are caused by falling. And women are more prone to fall than men. It may be due to their estrogen deficiency in the postmenopausal women that increases the incidence of osteoporosis among older women. And average cost of a fall injury is over $30,000, and combined cost of both Medicare and Medicaid is approximately $38 billion annually. Next. And here is the symptoms of hip fracture. As I mentioned before, there will be history of fall, and patient will have severe pain in the hip or groin region. He will be inability to get up from a fall or walk. There will be bruising and swelling in and around the hip area, and on the affected side, inability to put weight. Shorter leg on the side of the injured hip, that is also known as leg length discrepancy. And here is the picture of leg length discrepancy. Next. On physical examination, on inspection, we will look for if there is any swelling or visible deformity. And in a displaced fracture, when the patient will lie in supine position, the leg is held in external rotation and abduction position, and it will appear shortened. On palpation, we will look for if there is any tenderness, and there will be severe tenderness in the hip area. There are some special tests that are done for hip fracture, and those are active SLR test, hub test, and log roll test. This is the picture of classic straight leg raise test. In this test, the patient usually lies supine with one leg either straight or flexed at knee, with the sole of the foot on the stretcher. The other leg is kept straight and raised up by the examiner, and patient will be unable to perform the test due to severe pain. The next slide, I have the picture of hub test. This is something when we will instruct the patient to stand or hop unsupported on one leg, and we'll look for reproduced pain at groin area. And the test is positive with femoral neck stress fracture. The next slide. This is the picture of the log roll maneuver. It is the single most specific test for hip pathology. With patient supine, gently rolling the thigh internally and externally will produce severe pain at hip and indicate fracture. We should also assess the distal pulse, color, temperature, and sensation of the affected extremity and document it accordingly. And there is a significant chance of internal bleeding in hip fracture patients. Therefore, vital signs should be monitored and anemia should also be assessed. Thank you.
So in terms of risk factors for hip fractures, we need to think about what would cause weak bones and who is more prone to falling. So in general, our general risk factors include low BMI. So if you're low weight, it's just a sign of poor nutrition, and also you have less fat, so it's a little less padding when you do fall. Older age, the risk increases exponentially, and in females, especially with postmenopausal due to lower estrogen levels, we see higher rates of osteoporosis. And in terms of genetics, a family history of either hip fractures or falls or fractures in general increases risk, your hip fracture risk. And when we go to social history, things like cigarette smoking, alcohol use, poor exercise activity, because you're not strengthening any bones, and poor nutrition contribute to weaker bones. And specific medical conditions such as osteoporosis mainly, but things like Parkinson's and neuropathy that increases your risk for falls also increases your risk for fracture. And in general history of falls, fractures, and stroke increases future risk for hip fractures. Certain medications affect how strong your bones are. So glucocorticoids, they inhibit bone formation. So taking a lot of those will weaken bones, and things like antidepressants like anxiolytics and opioids and diuretics also contribute. So this is FRAX, a fracture risk assessment tool. It calculates the probability of a fracture that will occur in a 10-year span. So it uses age, your sex, your weight, height, and certain risk factors that I mentioned earlier, and as well as BMD, number 12. This is a bone mineral density, and that's a test is done for that calculates a T-score. The T-score, a normal T-score is from -1 to 1. So if you're less than that, you're at increased risk. So when from this score, if it's greater than 3%, there are two scores that come out of this tool. So there's the probability of a hip fracture and then a probability of a osteoporosis related fracture. So if you're greater than 3 for hip fracture, then you should consider getting treatment for prevention, and then greater than 20% should also for osteoporosis related fracture. So I have a case study that someone, if anybody wants to help me fill out, can you please raise your hand? And you can draw on this. You can draw on this slide too. So we have, someone can raise their hand, please, while I read this case. Georgia Robinson, she's a 68-year-old female. She's 5'3", weighs under 30 pounds, doesn't have any allergies, has a history of osteoporosis, rheumatoid arthritis, diabetes type 1, and hypotension. Her social history: has difficult seeing at night, hard of hearing, drinks a few glasses of wine, and takes hydroxychloroquine and prednisone for her rheumatoid arthritis, aldronate for osteoporosis. Fine. So let's just go over it together. Her age, we got that. That's pretty. Oh, they don't do animations. Sorry. I had this animate so that the box will reveal, but I guess I'll just write on it. Oh, but we won't see her score either, though.
I raised my hand. Can I try writing?
Yes, you can try writing.
What do I do? Click in here?
No, there's a pencil at the top left.
Oh, I see it. Okay.
Yes.
And then from there, I can write her weight. Oh.
It's in kilograms.
Oh.
By the way. So if anyone has a calculator on them, I think it's 59.
Okay.
Yeah, remember 2.2. Yeah, 59. And then her weight, her height is 160 centimeters.
And she does have a history of, no, she doesn't have a history of fracture, right?
Not that we know of, so I would assume no. Oh, and parent fractured hip, it means if they're parents, or if they have a family history of fracture.
Should I do no?
I guess assume no.
She is not a smoker.
Mm-mm.
She is on glucocorticoid, and she does have rheumatoid arthritis.
Yes. And then on the top right, we have 10, 11, 12.
Oh. Osteoporosis. Yes, she has, because she's taking Fosamax. Alcohol, 3 or more. A few glasses of wine and her score is 3.
No, that's a T-score. I just put that in. That's a -2. That's done by like a medical test. Um,
We'll put her age to 68.
yeah. Yep. Thank you.
Sure.
So, when we calculate this, since the transitions don't work, it would reveal the score, but I'll just tell you the score. It's for a major osteoporotic fracture, it's 27. Major porotic is a 27, and then for hip fracture in general, it's a 7.7. So since we don't, for the parameters, it's in the other slide. So it was 27 for a major osteoporotic, and then it was 7.7 for a hip fracture. So in general, if it's over 3, then she has a high chance of hip fracture, and then if it's over 20, she also has high fracture, like a general osteoporosis related fracture. So Georgia Robinson would need some sort of medical intervention to help prevent a future hip fracture. Okay, moving on. So when a patient does get a hip fracture first, and when they get admitted, they need to be placed into this traction boot, Buck's traction, and it's a form of traction where you got this boot attached to the injured leg, and a counterweight is applied, and that pulls, that kind of keeps the foot in line, aligned, and prevents like muscle spasms. And this is placed on before surgery. And then treatment for hip fracture is surgery. And there are 3 different types. So the internal fixation, that's this one. It's kind of like screws are placed in, help kind of heal, keep the bones together. Femoral head replacement is this one, the partial hip replacement. And so the femoral head, which is this, is replaced by this metal piece here. And then the total hip replacement is when the ball and like most of the head is replaced with this metal. And the hip compression, I believe, is an internal fixation device, another form of this one. Okay, so post-surgery, we have some management, medications such as heparin for DVT and PE prophylaxis, because long bone fractures increase risk of DVTs and PEs. Analgesics for pain management, such as morphine or Tylenol. And then, of course, trying to treat the original cause through treating of the osteoporosis through calcitonin, biphosphonates, and estrogen for women. And then complications of surgery, anemia can happen if the patient doesn't tolerate the surgery very well, and it's generally a poor prognostic sign of future, tolerance. Delirium, especially since these patients are older, it's quite common complication. And infection from the UTI during the surgery, or it was placed in during surgery, and then infection at the incision site. Also, pressure ulcers are common because these are older people and they will move around, especially after a hip surgery. And then we have a case study.
Okay, so now we're making a care plan, so we'll make it together. So let's dive in deeper to the scenario that we have. So we have Mrs. Georgia Robinson, a 68-year-old female brought to the ER by her son after a fall. So the patient's son states that their mother was trying to walk up a hill in their backyard and all of a sudden fell down. So on assessment, the patient's right leg looks shorter than her left and is externally rotated. So vital signs rate is 102, temperature is 98.6, respiratory rate is 20, oxygen saturation is 96. So the patient moans out in pain frequently and rated pain 8 on a 0 to 10 scale. So the doctor orders morphine 1 to 2 milligrams every 4 hours is needed for pain. So Mrs. Robinson has a history of osteoporosis, rheumatoid arthritis, and hypotension. The patient is currently taking hydroxychloroquine or Plaquenil and prednisone for rheumatoid arthritis and alendronate or Fosamax for osteoporosis. So she has trouble seeing at night and is hard of hearing. So the patient reports that she drinks wine every night. An X-ray was taken and shows an intertrochanteric fracture of the femur. So she gets admitted to hospital and is scheduled at surgery for the next morning. So based on this scenario, can you guys identify some of the risk factors that predisposes her to hip fracture? Can somebody raise? Oh, Carly.
Hi, I'm gonna say osteoporosis.
Yep. Thank you. Anyone else? Nee?
She has rheumatoid arthritis and hypotension, and she also like females and like over 65 years old.
Yeah. Good job. Another somebody? Okay. Taiba? Taiba?
Don't forget to turn your mic on.
Somebody? Oh, this is Taiba. Steven. Do you guys want to just say what it is?
Oh, I think. Okay. Can you hear me?
Yeah.
Oh, I think it's the side effect of medication.
Yeah. Yeah. Good. Okay, so let's go to the next slide. So these are, good job, guys. So these are her risk factors, her past medical history, osteoporosis, rheumatoid arthritis, and hypotension. Also the medication side effects. So she's taking hydroxychloroquine and prednisone, which causes nausea and dizziness. Also prednisone causes insomnia. So you might watch her during the day because that might, she might be sleepy during the day. Also, for the alendronate, we have GI upset, so might make more trips to the bathroom if she experienced side effects. Also, she's a female, over 65 years old, and she drinks wine every night, the sedative properties of alcohol, and she has trouble seeing at night and hard of hearing. Really big thing about this hip fracture is it's all about fall prevention because most hip fractures are associated to falls. So if we apply preventive measures, fall prevention, and safety measures that we learned from the past about make sure there's diffuse lighting or make sure there's no furniture blocking the way to the bathroom, especially when our elders go to the bathroom at night. So we will lower the incidence of hip fractures.
Okay, before I go on to the next slide, can anyone tell me some nursing diagnosis that applies to Georgia Robinson? Nee?
Acute pain.
Yes.
Okay.
Anybody else? Taiba? Taiba? Okay, Raven?
Risk for falls.
Yes, definitely. Um, Steven?
Hi. I'm thinking maybe impair.
Oh, what'd you say?
Hello,
Sorry.
can you hear me?
Yes, yes.
Oh, I'm saying it's impaired physical mobility.
Yes. So I'll go on to the next slide, the following next slide, and you guys are all correct. The nursing diagnosis that applies to Georgia Robinson is impaired physical mobility related to decreased strength and endurance secondary to hip fracture, as evidenced by X-ray showing intratrochanteric fracture of the hip. She also has acute pain related to fracture and soft tissue damage. She will be at risk for ineffective tissue perfusion related to unstable bones and swelling, and of course, risk for falls. So, okay, so the font is kind of messed up, but this is the nursing interventions before surgery. So ultimately, Georgia Robinson has to go to surgery for her hip fracture. So before surgery, you would want to assess pain on a scale of 0 to 10 before and after implementing measures to reduce pain. You will administer narcotics per the physician's orders, perform neurovascular assessments every 2 to 4 hours, and document findings. You would apply straight leg traction per physician's orders and encourage deep breathing and relaxation techniques. For sure that this patient may anticipate some anxiety before surgery, so it's important to give them some relaxation techniques, and that could also predispose their pain levels if they're more anxious. And then you would teach the purpose of traction and surgery and the procedure for performing isometric and flexion extension exercises. So after surgery, you would want to educate and demonstrate to the patient the post-op exercise to increase mobilization. Remember that prolonged bed rest, immobility, injury, and surgery increases the risk of DVT development. So you should, ways to decrease the risk of DVT development, you want to implement compression stockings and SCD device daily to decrease DVT development. You would educate the patient how to properly use a trochanter roll or hip abduction pillow. That will be, that's a picture on the right top hand side. That's the trochanter pillow. And you would also educate the patient how to properly change positions to relieve pressure with little pain possible. You would also want to educate how to properly use a trapeze bar when transferring in the bed, and that's the bottom picture. And then don't forget our fall risk precaution interventions. Even though they may be immobilized on the bed, there's still a possibility of them rolling off the bed, trying to reach for the call bell. So you would want to raise bed rails and put a call bear near the patient. So here's a picture of a trochanter roll. The trochanter roll can either be a cushion tool or a pillow that is used to hold the hip in place or in a neutral position, and it helps stabilize the hips of the greater trochanter of the femur of an immobile patient when recovering from surgery or operation. And it's mainly used to prevent external hip rotation and prevent the legs from rolling outward when in a recumbent position. So this is important because it could prevent further issues or even injury in the near future. And here's a hip abduction pillow, and it's similar to a trochanter roll. And it's a brace meant to hold the femur into the hip socket and prevent extra movement, and it prevents the leg from excessive movements away from the body. Next.
All right. Now on to nursing evaluation. So with a hip fracture, we can have all these nursing interventions, to increase the outcomes of the patient. But if we don't evaluate it, we won't know if it actually helped. So evaluation is a very important part of the nursing process. So the first thing we want to evaluate is if our pain management is effective. So we're going to reevaluate if how the patient is feeling. Do they feel a decreased rate of pain? So maybe on day one post-op, they may say they feel pain on as an 8. But by day 2, it should have decreased as we're giving them medication and we're putting them in comfortable positions. Next, we want to see if they're able to tolerate a full physical therapy session. So physical therapy is a part of, thank you. Thank you, guys. Physical therapy is part of, the process of them getting better and healing. So after a while, they should be able to tolerate it comfortably, without feeling like it's taking too much out of them or it's taking too much energy, or they can't breathe, or they're out of breath at the end of every session. It shouldn't be like that, but progressively they should be feeling better. The next one is that patient safely and effectively performs exercises taught by the physical therapist. So after they're taught these things, they might be going home a few days post-op, and you want them to be able to do these exercises correctively in front of you, in front of the physical therapist, so that when they go home, they can still exercise and still stay active to improve their care and improve their them getting better. Next, you want to the patient is able to express the importance of ambulation and exercise post-op. So if we teach a patient efficiently, they know why they're doing what they're doing, then I believe that there's going to be a positive outcome out of that. So if we're teaching them to ambulate and to exercise and to take whatever medications, specifically to prevent deep vein thrombosis or pulmonary embolism. If we explain to them how important it is, and we explain to their families that if they do get a deep vein thrombosis and then it turns to a pulmonary embolism and gets lodged in the lungs, they can possibly die, and it would not be good. So if they know, if they know why they're doing what they're doing, then there's going to be a positive outcome in that. And we also want to see some progression. So we want patient moves with increasing levels of comfort as healing progresses. So things should become easier as time progresses. From day one post-op to maybe day 3, maybe day 5. Then they're going home. It should become they should have more comfort moving and ambulating and moving, turning in bed. Shouldn't feel the same way as it felt immediately after the operation. A patient no longer needs 1 or 2 assists when ambulating. So initially, when they first come out of surgery and they're with physical therapy and maybe another nurse, and they need 2 people to assist them. It shouldn't be like that at the end. Maybe we go from 2-person assist to 1-person assist to just using an ambulatory aid, but there should be some progression in that. And the next is patient uses ambulatory aids in a correct and safe manner. So if they don't use it correctly, they may end up falling again and hurting themselves even more, because it's providing this false safety, or they may become relaxed when they're using it, and they may rely on it too much. And if they do that and they're using it wrong, they're going to end up falling and hurting themselves more. So it's important that we evaluate how they're using the ambulatory aid, if they're using it correctly, if it's a cane, if they're using it on the right side. And lastly, we want to check, so affected extremity has a normal color, temperature, and pulse. So we want the extremity, make sure that blood flow is good, make sure that it's not hot, that it's not, there's not edema there, edema, that there's no infection, and that it's as it should be. I have a short video I want to, yeah, I don't know if it, Marvy, can you press the video? I don't know if it's not letting me.
Yeah, it's not letting me either.
I don't think it'll work.
Okay, all right, no problem. So basically, this doctor was just, or I guess my takeaway from the video, which is just summarizing everything that everybody presented today. But it's basically saying that older population, specifically females, are the highest risk of a fracture, and they're usually low energy falls. So it's something as simple as tripping over something. It doesn't have to be something dramatic where they're like running and they trip over something and they fall and it's like high pressure. It can be a low pressure fall, a simple trip over a rug, and usually they will need surgery. If they don't have surgery, or surgery is highly recommended. If they don't have surgery, then life will just, it'll be a lower quality of life. They won't be able to do as much as they should be. They won't be able to do things on their own. So they highly recommend surgery. And lastly, things to prevent are having a healthy lifestyle where they're exercising constantly, and they are eating a healthy diet, vitamin D and calcium. And now I just have a few quick questions. So the first question is, a patient has sustained a long bone fracture. The nurse is preparing a care plan for this patient. Which nursing actions should be included in the care plan to assess fracture healing? Okay. Yes, Kenny, you can answer. this question. It says B. Yes, the correct answer is B. We want to make sure that we're assessing that and that there's proper healing and there's no complications with the blood flow, there's no infection, and we do that by checking the color, the temperature, and the pulses of the affected extremity. The next question is an appropriate goal for the patient who is post-op day 1 from a hip fracture with a nursing diagnosis of impaired physical mobility is A, the patient will interact with others. B, the patient will ambulate to the bathroom with assistance. C, the patient will have no skin breakdown, and or D, the patient will have a physical therapy consult. Does anybody want to answer this question? Go ahead.
I think Michelle said D.
Oh, D. I see two B's. B, B, B. All right. Yeah. So the correct answer is B. The patient will ambulate to the bathroom with assistance. All right. And this last, oh, you can't even see D. Okay. This last question, based on the following patient histories, which patient has the highest risk for a hip fracture? It's okay that you can't see D, so you can just choose from A, B, or C. All right. Does anybody want to answer this question?
Tiana is saying B.
B. What is D? C, because she's female with the history of falls. Okay. So the correct answer for this one actually is C. She is the oldest one there. She's a female that puts her at high risk. The asthma and the urinary frequency also adds to it, and she was hospitalized after a fall. So she has a history of fall that relates 2 years back, and also she's taking that fluticasone, so yeah, for asthma. So these are all adding into the risk for hip fracture. And is any questions?
I think Carly is raising her hand.
Okay, thank you. Carly, do you have a question?
Carly, do you want to ask a question?
I think you wanted to answer.
Raven, did you have a question?
Yes, I had a question about the last. Michael or Marvin, can you go back? Would patient B be like the second highest risk because he fractured his femur, or no, because he's the youngest?
Definitely that does pose him to have that risk. So yeah, he'll have the second risk but also he's a male, so males are lower at risk.
He's male, but he fractured his femur from a skiing accident, which is not really a risk factor in that sense. Like, it wasn't a fall. This is like uncontrollable, you know? It's like if you got a fracture from like a car accident, you know?
Okay, thanks guys.
Okay, thank you. All right, so that pretty much sums it up for our presentation. Thank you for listening. And thank you. Thank you.
Very good job, guys. Great job. Happy birthday, Michael.
Thank you. Thank you.
It's too bad you have to spend it socially isolated.
Yeah. All right. Sorry.
Okay, I'm going to queue up our next presentation if there's no more questions for our last group. But great job, guys. I think even in this remote setting, you made it a very interactive presentation, and I thought that was very good. So now we have post-op frailty, and you all have your mics on, so whoever wants to take it away can just take it away.
So our group is presenting about post-op frailty, specifically in people of color. So I don't think the video is gonna load, but here's this was a WHO video regarding the role of rehabilitation for people and how that it changes the quality of life and improves people's quality of life after accidents or just from chronic conditions and disabilities that they're suffering from. So right here is a case study that we're going to be referring to throughout the presentation. So I'm just going to read it really quick. It's a 69-year-old male, Mr. Barr. He previously had a below-the-knee amputation 4 days ago and currently is being prepared for discharge. You know that he lives alone in a 2-story townhouse with his 65-year-old wife. He has a history of hypertension, type 2 diabetes, and hypercholesterolemia. He gives the impression of a tough guy who has it all under control, but you have observed him looking frightened and depressed. So this case study came from the textbook with several edits. So right here, so some key terms to know about frailty and disability is that frailty is defined as a condition in which a person has poor endurance and weakness, whereas disability is a process that begins with an illness or a disease, which then leads to impairments in basic physical activity over time. So, sorry, did someone say something? No, okay. So in recent research specifically in regards to people of color about frailty and disability is that in disability, then there's actually 3 components involved in the functional limitation model, which disability is based off of. So the 3 components are risk of onset, the initial level of impairment, and then the accumulation of impairment after the onset. So recent research is suggesting that other than being important to understand that there are actually racial disparities in functional impairment overall throughout the model, it's more important to recognize that there are disparities across the different components of functional impairment for people of color. For example, the risk of onset of functional limitation and the initial level of impairment at onset of functional limitation for people of color is higher than for their white counterpart. Therefore, it's important for us as nurses to separately consider racial differences in the risk of onset, initial level impairment, and the subsequent accumulation of impairment over time for each of our patients post-surgery individually. Also, recently there has been this concept of double disadvantagement of disability in the process of disablement. So this is the recent concept which provides a more nuanced understanding of the disablement process experienced by people of color specifically. It was found, and it's being publicized right now, that race and ethnicity as risk factors experienced by people of color leads them to have an increased double disadvantage in the risk of transitioning from health to disability amongst African Americans and Hispanics specifically, and specifically due to their experience of chronic condition, which is different from how their white counterpart experiences it. And similarly, there's a multiplicative risk where each chronic condition that they have hastens the onset and the initial levels of impairment of function. And as nurses, it's just important for us to be aware of this because it highlights the increased risk of hastening the process of disability for ethnic and racial minorities in the presence of chronic conditions, which a lot of times these are exacerbated by frailty and after a surgery. There's also another video by the WHO that talks about how currently the rehabilitative process isn't really geared towards people that are minorities and people of color, which I'm going to explain. So some concepts for us to know is that rehabilitative care is focused on returning individuals to their previous level of functioning. Therefore, after surgery, a lot of patients go to rehab in order to return to their previous level of function. For example, if someone had a hip fracture, they'll go to rehab to regain mobility and to regain muscle strength, whereas restorative care is focused more on maintaining or improving their current level of function to avoid decline and complications and achieve the highest possibility quality of life for them. So for example, patients that have multiple chronic conditions like diabetes, hypertension, sarcopenia, maybe cachexia will have restorative care after rehabilitative care. So specifically for people of color, it was found that post-surgically, a higher proportion of African American older adults are actually at lower functioning and had lower odds of receiving rehabilitative care compared to white people. Additionally, specifically white people are offered rehab services at a higher rate than their African American counterpart, and additionally, they utilize rehabilitative services at 33% increased rate than their minority counterpart. Other than just an overall increased rate of using rehabilitative services, they utilize rehabilitative services inside the hospital more often than their minority counterpart. And in the outpatient setting, they're more likely to be utilizing home-based rehabilitative services compared to their minority counterpart. This is important because as nurses, it allows us to be aware of the fact that during the inpatient and outpatient process, there's disparities in rehabilitative and restorative care usage amongst our people, amongst our patients. Patients are most likely to use convenient rehabilitative services, such as within the hospital setting and home-based setting, compared to when you have to go to a rehab center. So this disparity in offering services and utilizing services leads to lower health outcomes for our minority patients. And additionally, recent research has outlined the specific barriers that leads to lower usage of rehabilitative services for our minority patients, and a majority of them is the three main ones that was identified was language barrier, cultural differences in service delivery, and limited reach to actually deliver culturally competent care to our patients. So overall, the barrier leads to reduced effectiveness in rehabilitative and restorative care for the minority population, and which leads to less effective management of chronic conditions and increasing the risk of frailty and disability amongst our patients of color, specifically after surgery. And additionally, so this one, all these resources are referenced within the PowerPoints if you go to the drive. So if you want to look at them, you can access them there. And because specifically this 10-step guideline is a new template to specifically link minority patients with community resources to effectively manage their chronic conditions and or disabilities post-surgically. It provides specific methods to actually introduce and allocate resources to our minority patients. And Camille will speak.
Okay, can you hear me?
Yes. Yeah, we
Yes.
can.
Okay, so according to the US Census Bureau survey, 35% of people aged 65 and over have some type of disability, and this can be a decline of the senses or the ability to take care of themselves. Specifically for frailty, people aged 85 years and over are estimated to, the estimate is the population is 25 to 50% in that age range. And that is due to lengthening lifespans, as we have gone over in class. I believe it was even the first week, because older age means a higher prevalence of frailty and disabilities, and also chronic diseases, as Victor mentioned, are also major risk factors, particularly diabetes and obesity. So some key points about disability: it may come suddenly, or as a result of an accident, or as a pre-existing condition worsening, and it can create new vulnerabilities or worsen those that were already there. And these patients that are frail or disabled have higher risk for post-op complications and higher risk of mortality. These new or worsening problems can strain relationships or roles, leading to issues like an altered body image or loss of independence. The attitude that the patient displays towards their disability has been found to be more important than the actual severity of the disability or frailty, because they might, if they might fall into depression, they might self-isolate, or they can try to overcome it with use of therapy or assistive devices and changing their lifestyles to kind of counteract the problems that they're facing. And to add to that, family can also have a large influence on how the patient reacts, especially if the disability is viewed as shameful. The patient might then isolate or fall into depression even more. And it's important that families don't overindulge the patient and allow for as much independence as possible. And also a big point is these losses of function or independence will be mourned by the patients, and they will go through those 5 stages of denial, anger, bargaining, depression, and acceptance. So it's important to help guide the patients through those. And in that graph on the left, you can see that the rate of disabilities is increasing across all ethnicities, but it is highest for the Black and Hispanic population. And especially at ages 80 and over, it's the highest there. Okay, so on the left, we have the different types of disabilities: mobility, self-care, and household activity, with household activities being the most common ones. And that includes preparing meals, shopping, just general housework, or taking medication. And that is also increasing for patients 70 and 75 and up. On the right, we can see that this growth of people with disabilities isn't slowing, and based on current data, the prediction is that in just 5 years from now, in 2025, the number of households aged 65 and older will increase to 13.4 million households that have a mobility disability. So it's an issue that's gonna be always current, I suppose. And then just some key points of rehab care. You want to be guided by increasing self-care capacity, eliminating or minimizing limitations, and performing tasks for the patient when they cannot do so themselves, but also remembering to allow the patient to be as self-independent as possible for them. And then there's some guidelines to remember. So you should always assess the patient's capacity and then plan their care to their ability. Try to maintain or increase the function, and your goal is to promote their well-being and quality of life. The rehab care will require a multidisciplinary team. It's important to remember not to equate physical disability with mental disability, and treat the elder person as mature and intelligent. To provide adequate time for exercises or just simple tasks. People also might want to hurry it up just to save time, to be efficient, but it's important to give them that independence. To prevent complications like skin breakdown, isolation, or fall risk. And to stay positive, because if the person that's taking care of you isn't feeling positive about the possibility of recovery or just maintaining your function, then you might not feel so good about it yourself. And that's
Okay, hi. Can everyone hear me?
Yes. We can hear
Yes.
So
Yeah.
I'm gonna be talking about the functional assessments of ADLs. So when you're assessing a patient generally or post-op, you want to see how they perform in their activities of daily living, or ADLs, and also their instrumental activities of daily living, or IADLs. So ADLs are basically the self-care needs or the basic needs that a patient needs to have, such as eating, washing, dressing, toileting, or moving. And IADLs are more complex skills needed for an individual to function independently, such as preparing meals, using the telephone, cleaning, traveling, or safely using medications. And this is a table in our textbook, table 32.2, and it shows the assessing capabilities for ADLs. And if I could, I don't think I can zoom in here, but for eating, when you're observing a patient during meal times, you can see if they're able to use utensils or cut their meats. For hygiene, you should be able to see if a patient can brush their teeth or bathe themselves. For dressing, if they can put their clothes with assistance or by themselves. For continence, incontinent less than once daily would be partial independence, and total incontinence would be dependence. For toileting, you want to see if a patient can use a bedpan or a toilet without assistance. And for mobility, you want to see if the patient can get out of bed or if they can ambulate with one person assist or two person assist. And throughout your practice, you want to describe a patient as totally dependent, partially independent, or independent in their ability to perform these activities. Because as a nurse, you can think about assessing your patient's level of independence to delegate tasks during your shift and when you give reports, so appropriate interventions can be planned. So some universal screening tools are going to be the CAT Index of Independence and ADLs. And this just measures the patient's ability to perform certain tasks. There are 6 functions: bathing, dressing, toileting, transferring, continence, and feeding. And you basically give 1 point if the patient can do this independently, and 0 points if they're dependent and need assistance. And scores of 6 indicate full function, 4 are moderate, and less than 4 would be just poor or severe functional impairment. And this assessment is sensitive to changes in declining health status, but it does not assess more advanced activities of daily living, so we should be mindful of that. I wanted to include another scale called the Cleveland scale for ADLs. This tool can be used for persons with impaired cognition, such as our patients with dementia, and it may aid in revealing the impact that cognitive deficits have on function. It consists of 46 items encompassing 15 domains of everyday activities. And if you go on the PowerPoint on your own time, you can click through like the slides to see the transitions. The assessment is very thorough. The ratings are made on a 4-point scale, and research shows that the Cleveland scale is sensitive to increasing in functional disability across a broad range of dementia severity. So that's something that's available. I think it cut off, but it says Lawton-Brody IADL scale. And this is a tool used to assess independent living skills that can be used as a baseline assessment tool to compare baseline function to periodic assessment. So if you take a look here to the right, we have 8 domains: ability to use telephone, shopping, food preparation, housekeeping, laundry, mode of transportation, responsibility for own medications, and ability to handle finances. And the summary scores range from 0 to 8, 8 being the highest function, 0 being the lowest function. And for men, it's 0 through 5. I remember reading that once they were making the scale, they wanted to account for biases. That's why the score ranges are different. And it can be done fairly quickly. It takes 10 to 15 minutes. But one of the limitations is that you can't physically see, you can't see the patient perform the function. You have to rely on self-report. And also, it may not be sensitive to small incremental changes in function similar to the CATS test. However, this is also available in the clinical setting, and you should advocate for patients to be frequently monitored using these scales. And Victor will now explain how this applies to our case study.
So in this section, Mr. Barr is 1 day post-surgery for his below-the-knee amputation. So at the beginning of your shift, the nurse performs an assessment of ADL using the CATS index. So the notable findings are that he needs assistance going to the shower, he needs assistance getting up from the toilet, and he needs assistance getting out of bed. So what is Mr. Barr's level of impairment according to the CATS index? So we'll just hop back to the CATS index. So what would you rate his score as, and what level of impairment is he suffering from right now? Okay, so it said that he needs assistance bathing. So that's 0 points right there because he's completely dependent. Let me see if I can rate that right on that. Yeah, for dressing, there's no notable findings, so we're gonna assume that he's completely independent. So for toileting, he needs assistance getting up from the toilet and going to the toilet. So he's dependent in that aspect as well. Oops. Transferring, he needs assistance getting out of bed. He's continent, and he doesn't need assistance being fed. So his score would be a 3 because he needs assistance bathing, toileting, and transferring. Sorry, I wrote the wrong information on here because it looked weird on my screen. So he would be classified as being moderately impaired at the moment. And the second portion of the case study would be, do you guys believe that the CATS index is the best tool at this time to be using to assess his level of functional impairment? Does anyone want to take a guess? Well, yes, Kenny. As Kenny answered, it would be actually the best tool to use as this moment. So as Shanta said earlier, the CATS index is very brief and it only addresses several of the factors that we use to measure impairment in our elderlies. But however, because in the moment he's in a hospital setting compared to living at home, the CAT scale is adequate in determining his needs from the nurses. And however, if we went back to the beginning of the case study, it was saying that it was preparing for discharge. So upon discharge, we would probably use a more specific scale, such as the Lawton-Brady scale, as Shanta described earlier, to more accurately assess his needs and to anticipate the needs for Mr. Barr when he's transitioning to the outpatient setting. So as we remember, one of the main things as nurses that we do is to prevent post-surgically, especially like frailty and loss of functioning. So because we can see the fact that right now he's moderately impaired, we can perform interventions, which will be described later, to promote rehabilitation for Mr. Barr starting in the inpatient setting, because the best way to prevent disability, the best way to manage disability is to prevent disability. And here are some interventions to maintain functioning.
Yeah, so like we were saying for post-op patients, we want to make sure that we're providing certain interventions such as positioning, range of motion exercises, use of mobility aids, bowel and bladder training, and activities to promote mental functioning. Oops, sorry, I'm not, okay, I'm on the proper side now. So I'm gonna start with proper positioning. Proper positioning is super important because it allows you to optimize certain major systems within the body, promotes comfort, and prevents complications. So the systems that are most affected by proper positioning and alignment are the respiratory system and the circulatory system, which makes sense because we said in other classes, like you can prone a patient if they're having ARDS, or for circulatory system, you know that if you raise a person's leg, less blood will go and pool at the bottom of their legs, things like that. The complications of poor alignment include contractures and pressure ulcers. And a really important nursing indication for proper positioning is that you have to be very cognizant of the fact that some patients do not have any, are not able to move their bodies, such as quadriplegics, stroke patients. And so you have to be responsible of maintaining proper body alignment and rotating a patient as per your hospital's standards. So over here, I just have supine position, prone position, lateral position, and chair position. And it shows the exact ways that you should make sure that you have your patient in order so that you, as you can see, they use pillows for lateral positioning. That's to prevent pressure ulcers because you're going to be on bony prominences in certain body positions. So for range of motion exercises, before I show you the slide, even though I know I peeked it, what do you guys think is a good amount of, what do you think older adults should do? How often do you think that they should incorporate range of motion exercises in their life, in their day, in their week? Anyone? So daily 30 minutes. That's a good one. That's a good guess. The textbook didn't necessarily give a time limit. In regards to frequency, does anyone want to guess? You can type it in chat. Yeah, Raven got it. So it's super important that you want to encourage that an older adult gets daily activities. So I'm going to bring the slide up. So range of motion exercises are super important because they promote joint motion, muscle strength, stimulate circulation, and help with the functioning capacity. And they also prevent contractures and those complications that I had mentioned earlier. So there's certain degrees of exercises that can be done dependent on where your patient is at in their post-op journey. So there's active range of motions, which is where you are giving where the patient is completely independent, doing the range of motion exercises. Usually you would be modeling for them in front of them so that they know what movements to do. There's active assistive, where you're giving some assistance, and then passive, where the patient does not have any involvement in these exercises. So for the basic range of motion exercises, like we said, they should be done daily. And I'm just going to show a couple of different exercises that especially our elderly patients, if not everyone, should be doing. So there's flexion, adduction, supination, pronation. So we have the shoulders you have to focus on, the elbows, the wrists, the knees, the hips, the cervical spine. We also have to focus on thumbs, fingers, ankles, and toes. So basically any of the joints are very important because if you don't use it, you lose it. And so in the next slide, I have something to help with documentation. It's from the textbook. And it shows the normal ranges of each joint. Can someone guess what is a really important nursing implication for range of motion exercises? Something that we covered in fundamentals. Just think about, let's say you're doing passive range of motion or assistive range of motion. What is something that you have to be cognizant with the joint? If anyone wants to volunteer or type. Yes, Julia got it. So you need to make sure that whenever you are doing these range of motion exercises, you offer support below and above the joint being exercised. Another thing is that you have to move the joint slowly and smoothly, and the nurse should try and exercise them around 3 times a day if they have the time. That's ideal. So a very important thing to remember is that you should never force the joint past the point of resistance, or if they have any pain, don't continue pushing them. You think when you're working with younger patients, you like push them past their breaking point, and that's how you train to get stronger. But with our elderly patients, you need to make sure that you don't do that, because those contractures are very stiff, and if you go past it, you can break ligaments, break bones. And make sure that you document joint mobility, and that's super important to note for the progression of the joint. See how it's doing through hospitalization. So there's a couple of things that you should do, some reasons that can indicate for you to stop range of motion exercises. And the majority of, they're written right here, but basically, the gist is that range of motion exercises can be very exhausting for an elderly patient, especially post-op. And so you need to make sure that you stop some exercises, let them rest, especially. But so let's say if they have a resting heart rate of above 100 beats per minute, if they have dyspnea, if they're dizzy, if they're starting to get confused and restless, if they have angina, those are all indications that you should stop the range of motion exercises. And now I'm going to move into mobility aid and assistive technology. So you need to make sure that you're using the correct devices for each patient. And that's super important in terms of making sure that you're not making a patient dependent unnecessarily on an assistive device, so that they can be at their optimal functional capacity, hopefully without devices. But if they need it, make sure it's the right device that offers the type of support that they need. So I just made a little chart which highlights canes, walkers, and wheelchairs, which is what I'm going to be discussing. And for canes, they offer a wider base of support, but they're not meant for weight bearing. Walkers, they offer more support than a cane, and you could bear weight on your walker. And for wheelchairs, that's meant for people that have certain disabilities and they're not able to ambulate, such as paralysis and cardiac diseases. Like, let's say directly after a heart attack, you don't really want patients ambulating that much. So my slide got cut off over here. That said canes, and it got disoriented, but that says canes. So the top photo shows the different kinds of canes available and the different bases, which offer varying levels of support. And sizing is very important in terms of canes. They have to be fitted per person. And the way you, oh, I don't know how to bring it back.
I can do it.
Oh, okay. Thank you. Sorry about that.
Oh, wait. I think I almost got it. And we just got to get back to your slide.
I was on slide 26.
Okay.
I can't see anything yet, though. Okay, perfect. It's back. So, like I was saying, for canes, you have to make sure that they're fitted from the greater trochanter to a distance 6 inches from the side of the patient's foot. And the way that you use a cane is you have it on the unaffected side. So on your strong leg, some people say, that's the side that you're holding the cane, and it advances with the affected limb. So your good leg will go forward, and then your cane with your affected leg will move following. So next I have walkers, which is once again cut off. Sorry about the graphics for some reason. On the top, I have the different walkers that are available. There's regular walkers, walkers with wheels. Sometimes you'll see patients putting like tennis balls so that they're able to slide better. And walkers offer a lot of support and stability during ambulation. Their sizing of them has to be from the patient's trochanter to the floor. The way that they hold it is they have to hold the side of the walker with their elbows flexed. And in order to ambulate, the person advances and the walker, and then they step forward. advances, yeah, sorry. And then when going into a seat, it's very important that you're getting stability from the chair, the armchairs, the armrest on the chair rather than using the walker for support, because that's very unstable. So you want to make sure your hands are planted on the arms of the chair. And with wheelchairs, it's important that the seat is larger than the person's sides to prevent pressure and friction. The feet should be at a flat position, and you need to make sure you're checking the ease of the wheels and the mechanics of the chair frequently. And now bladder and training.
Okay. Hello.
Oh.
So I'm going to talk about bowel and bladder training. Incontinence can have a profound impact on person's well-being and health. Skin breakdown can result from the moisture and irritation. Make sure to clean and dry patient's skin. May cause falls if urine or feces are on the floor, so check floor and clean the floor. Educate the patient about bowel and bladder training. Training should begin as early as possible. Consistency is crucial in training programs. Bowel training. It is important to establish consistent time to eliminate. Instruct the patient to lean forward or prop feet on stool. This position increases the intra-abdominal pressure and helps with bowel movement. If necessary, use glycerin suppository 30 to 45 minutes before scheduled bowel movement. Exercise, good fluid, and fiber intake are also important. Bladder training. First, of course, we need to make sure that bathroom is easily accessible. Instruct the patient to drink at least 1,500 milliliters of fluid daily unless contraindicated. Method can be used, which is leaning forward and pressing on lower abdomen while trying to urinate. Also, stimulating voiding reflex can help. Examples include pouring water over perineum, drinking water while on commode, or stroking abdomen with inner thigh. Kegel exercises can lead to an improvement of controlling urinary incontinence. So Kegel exercises. This exercise can increase the strength of the pelvic floor muscles. So first, you need to void prior to starting Kegel exercises. Get in a sitting or standing position. 3, tighten the pelvic floor muscles for about 5 seconds, then relax. Do this several times in a row, and make sure not to tighten the muscles of the abdomen, buttock, or thighs, just the pelvic muscles. And gradually increase the muscles tightening time to 10 seconds. Perform at least a set of 10 exercises in a row. Repeat several times throughout the day, every day. And results should be noted in about 2 to 3 months. Next one, this one is maintaining and promoting mental functioning. So efforts to restore, maintain, and promote mental functions are also important. Mental functions can deteriorate if not exercised. Mental stimulation is a highly individualized process. Being consistent and listening are crucial. So I'm going to share 2 mentally stimulating activities we can do. So first one is reminiscence. It's a life review. Studies have supported that it can improve memory, validate existence, resolve past conflicts, and enhance quality of life. We can do this by playing old records for the patient, showing old photographs, asking the patient what memories arise, and asking the patient to describe important life events. Another one is reality orientation. Patients with memory loss, confusion, and disorientation require efforts to keep them mentally integrated. We can do review of day, date, weather, next meal, and next holiday. Also, we can use calendars, clocks, holiday theme decorations, and staff interactions can be actually very helpful to those patients. For example, when you enter the patient's room to get medications, you can start the conversation saying, "Hello, Mr. Such and Such, how are you this Monday? It's April and today's weather is sunny and warm." Conversation like this can serve as an opportunity to enhance orientation. Last one is using community resources. Each community has its unique resources for persons with rehabilitative needs. We have social workers, physical occupational therapists, speech and hearing therapists, rehabilitation and vocational counselors. Also, local libraries and health departments can provide valuable assistance.
Okay, so we're going to return back to our case study. So one of the first question is, during the inpatient time period, what interventions do you think are appropriate for Mr. Barr to maintain functioning and limiting his functional impairments that he would have after surgery? You can just type it in the chat if you don't want to say it out loud. Yeah, like Carly said, one of the most important things we can do is to provide the mentally stimulating activities for our patients, like keeping them oriented. So older adults, we know, are more likely to experience delirium and confusion in the acute care setting. So keeping them alert and oriented to time are important, and other interventions we can do includes like promoting adequate sleep hygiene, making sure our patients sleep, limiting noise on the unit, and all these things help us prevent our patients from being confused and delirious, which exposes them to a risk of injury and other problems that can ensue post-surgery and in the outpatient setting. So other indicated interventions we can do are things like range of motion exercises. So immediately post-operation, our patient had a below-the-knee amputation. So he will be bedbound for a period of time. So during this time period, we're exposing the patient to risk of functional impairment by decreasing the muscle use, muscular atrophy, and other things that can cause functional impairment later on, and frailty, which we want to avoid. So range of motion exercising, having the patient push against us and use his muscles. And additionally, we can set up a PT consult. As the patient now currently has a below the knee amputation, he's going to be needed to be fit for prosthetics. However, that might be done in the outpatient setting. So while inpatient, we have to promote and facilitate early ambulation. Other than preventing things like pulmonary embolisms and DVTs, it's also very important for a patient to just maintain muscular strength. So the time when he leaves the inpatient unit, he's not going to be frail and disabled. So a PT console for required mobility aid would allow Mr. Barr to move as wanted and independently at the same time and safely. So the second part of the case study returns to the beginning, where the patient is set for discharge today. So what are some considerations we should take as a nurse and account for his discharge, teaching, and planning, and any referrals that we need to make, keeping in mind that Mr. Barr is an African-American older adult? Yeah, like Carly said, his home, like things, like I said, he lives in a two-story house and with his wife that's an elderly. So there might not be enough support for him outside of the inpatient unit. In the inpatient setting, he has nursing attendants and people that will assist him, cook for him, make sure he's safe. But in the outpatient setting, he might not have those. So social work consult might be necessary. Home health aides might be necessary. We can set him up with case management with his insurance. All these things ensures the fact that he will have a successful transition from the inpatient unit to the outpatient setting. And also other things that I wanted to bring to light was the idea earlier where I said that minority older adults are less likely to utilize and be offered rehabilitative services compared to their white counterparts. So specifically for Mr. Barr, rehabilitative services are of course indicated. He had a below the knee amputation and he has multiple chronic conditions that are likely to oh yeah, like Michelle said, PT consult as well. So back to what I was saying, it's all these multiple chronic conditions and his new below the knee amputation are likely going to impact the healing process and lead to frailty and disablement later on. Therefore, it's important for us as nurses to connect him to the rehabilitative service and or case management, because case management is a program outside that will ensure that he is connected to rehabilitative services and other needed services that he might have to promote independent functioning in the outpatient unit, in the outpatient setting. Additionally, if you noticed earlier that on assessment, Mr. Barr was exhibiting fright and being a little down. So social work or psychiatry consult might be indicated, because as nurses, our role isn't to assess for any psychiatric condition or mental disorders. Instead, it's to provide referral as needed. And because we've noticed Mr. Barr has been being frightful and a little down, we can provide the consult. And I think to wrap up our presentation, we wanted to talk about how, like, as nurses, we always want to promote the best outcome for our patients. So other than just stabilizing our patients and making discharge information, we should keep in mind how surgery places our patients at risk for frailty, because they will be weakened after the surgery and might experience some impairment. If we don't promote functioning in the inpatient unit, such as by performing these range of motion exercises to preserve muscle functioning and to encourage our patients to ambulate early and to perform these Kegel exercises and other things, we are placing our patients at risk for complications, and they might not have a successful transition into the outpatient setting and at home. So as nurse, bringing in the idea of gerontological nursing, we want to be promoting the highest possible quality of life and wellness for them, especially post-surgery, because it places a lot of stress on their body and they might not have a prolonged healing process. So we want to promote functioning and independence at the very beginning, which is right when they come out of the surgery. So all the interventions we listed earlier are very important for our patients. And are there any questions? If not, we're done.
Very good job, guys. Great presentation to both groups today. And I think we had a very successful first online remote class. So for next week, I'm going to be posting our lectures. They're going to be on endocrine and mentation and integumentary. So it's a lot of content. It won't be a live class like how we have today, because I won't be available. Next week was supposed to be our spring break week, so I had scheduled myself to work at my full-time job, so I won't be available to host you all in a live session, but it'll be recorded for you, available online, just like how the infection and cancer lecture were. And we also won't have presentations next week. We'll pick that back up on the 20th. So great job, guys. It's a beautiful day. Hopefully you can go out and enjoy some sun. And just email me if anything comes up. Have a great day, guys.